You to Delana Williams. She is our Director of Coding and Compliance here at Welter Healthcare. Delana has close to 30 years of end-to-end revenue cycle experience and is truly instrumental in helping our clients with all aspects of coding and billing compliance. So I know she has a lot of information to cover today. This webinar may not take the full hour, and we do want to leave some time for Q&A. So if you have questions along the way, we're not going to stop and answer them, but please drop them into the chat so we can answer some questions at the end. So with that, I will hand it over to Delana.
Thank you so much, Jen. Hello, everyone. Welcome back to anyone who's joined our past webinars. And if you're new joining the webinars, thank you so much for being here today. This is such a privilege. And I just look forward to sharing some of this information with you. And we always want to start out with our disclaimers, which means that what we are looking at is the most updated industry information. But we always urge that you do your research and, you make sure that all of the information that we've given you is just up to par with what you've been able to find in the industry. And we do also like to provide you with all of those links and those sites, those authoritative sources that we pull information from as well. So we will go ahead and get started. So our session today was set to be completely different. So we were all nervous. I think everyone across the industry was nervous about our telehealth flexibilities ending at the end of this month. And in our last webinar where we did the overall 2025 updates, we promised to have an update and to track what's going on with telemedicine in the industry. And so we've got a new flex, and our telemedicine deadline is now pushed out to April 1st. To September 30th. Now, although we do have this flex, and it was supposed to end on April Fool's Day, we all know that this is no laughing matter. There's nothing foolish about what's going on right now in our industry. And I'm not sure if everyone remembers this, but this was that big last minute clutch that we had on December 21st last year. It was extending the pandemic telemedicine flexibilities through the end of March. So here we are, just last week, we were waiting with bated breath to say, what kind of call are we going to have on the 21st? Are we going to have to just hit the floor running with having to take that step backwards? But lo and behold, here we are. We do have another intensive cliffhanger. This push was just introduced on March 10th, and our president just signed off on it on March 15th to extend telehealth flexibilities through the end of September. But what I urge here is do not get comfortable. Please begin contingency planning as soon as possible. We're going to go through all of that today. And I'm just so happy that this call actually converted to let's prepare, other than, we all just have to scramble to make it work. This may literally be the flexibility that we have. And just to give you some insight that on October 1st of 2025, if the government doesn't take action again, that these telehealth guidelines will literally impact about 6 million seniors alone, millions of people, but about 6 million seniors overnight. So that's why this is just so serious for us. And so in summary, we are 2 years post-pandemic. We've now been given a 6-month flex, and this means that all leaders can and will put their heads together to brace for the impact. I can't understand how we're still having this discussion on this matter in the setting of all the good that telemedicine has done and is continuing to do. Post-pandemic or not, we would think that it would be a no-brainer, but we just have to prepare. No matter what, we have to prepare, and we cannot get comfortable. So I believe preparation takes repetition, and in repetition of understanding what we're up against, should we have to go backwards. And then it's repetition of knowing what we need to do to prepare. And that is what we will do here at Welter moving forward, which we'll get more into later on. So let's unpack this more. Some of you may be aware, and this will be a nice refresher, but what are we up against if we go backwards? Well, we're talking about these telehealth waivers and all this flexibility. These were all put in place during the pandemic. So statutory waivers. So these statutes are written into law and they're passed by our legislative bodies, which would be like our US Congress. So these provisions that our legislative bodies are able to give or to exempt the regulated parties, which are us, the healthcare industry, they allow us to become exempt to specific legal requirements when these laws that they have in place are a poor fit for a given situation. So we all know that our poor fit was COVID-19. Everybody, no one could leave home. EDs overnight were empty. So telemedicine had to be put in place. They had to give us a flex on these laws that were in place. And then we have our regulatory waivers. So these are laws or rules or orders that are issued by an executive authority or a regulatory agency. We would think that our regulatory agency is CMS, right? So the purpose is to regulate us, to regulate our conduct. They're acts of control over something. So our regulatory waivers are to lax the controls, which these controls were laxed around virtual and direct supervision. And this is situational. So we know that our non-suitable situation, again, was COVID. So the poor fit of the laws was COVID, and this inconvenient situation was COVID. So now, statutory waiver breakdown. So the pandemic ended around May 11th of 2023, 2 years post-pandemic. Okay, and so now we're looking for another flex from our government somewhere around September 30th. But what we will have to go back to is that patients will have to be located at what they call approved originating sites in order to receive the telehealth services. So the patients have to get up and leave their homes and go to these approved originating sites, which are physician or practitioners' offices, hospitals, critical access. We have our rural health and our FQHCs, critical access hospitals, skilled nursing facilities, and some community mental health centers. And then there are specific circumstances like renal dialysis facilities that patients can go to receive telehealth, mobile stroke units, rural emergency hospitals. Now, the only times, if we go back, the only times that patients do not have to leave their homes and what can be considered an approved originating site at home is for treatment for substance abuse disorders and the co-occurring mental health disorders that they have around substance abuse, standalone provisions for mental health services, and then home dialysis for patients with end-stage renal disease. Now, geography lessons. So not only do our patients have to leave their homes to go to these approved originating sites, these approved originating sites have to be in specific geographical locations. These are the non-metropolitan statistical areas, MSAs, or the HPSAs, and these are rural health professional shortage areas. And then there may be some practices that are participating in federal telemedicine demonstration projects. So the patients have to leave their homes to go to approved originating sites, and then these approved originating sites have to be in these very specific geographical locations. So again, the exceptions to where the patient's location needs to be and the geographical restrictions for them to remain at home, again, treatment for substance abuse disorders and those mental health disorders surrounding them, the standalone just mental health issues that the patients have, home dialysis for patients with ESRD, and treatment and diagnosis of acute stroke. This specific to the geographic locations. So that means virtual care or direct supervision will take a hit, will take a massive hit with what is considered direct supervision that we've had these flexibility waivers for, and physical, occupational, and speech therapy that can literally be shut down. So very serious. Here's another really serious hit is hospital at home model. This is the patients who are at home and they receive the acute care at home instead of the hospital. So without another waiver, like I said, 6 million seniors will be affected by this, and any of those other vulnerable populations of folks who really need to have those hospital at home services. Hospitals will no longer be able to bill fee for service to Medicare or Medicaid for hospital at home services. The hurt piece here is that any hospital continuing hospital at home for their patients, which most providers want to, but the hospital has to absorb all of the risk. Same goes for the clinic when you think about it. But billing can still be allowed to like the private payers or instituting self-pay for patients. So that's another part of that contingency planning. Now, let's just say, for instance, the Congress does not give us a flex before September 30th, and we have to go back. We have to go back to all of these things that we're discussing right now. But let's say they see how everything is crashing and burning around us, and they're like 90 days later or sometime in the new year, they're like, we have to reinstate these flexibilities. With Medicare, you cannot retroactively bill. So even with that gap, once that sets in place and we go back and they decide to reinstate it later, we can't even retroactively bill. That would have to be like another kind of law that they pass if that was to happen. So pretty significant stuff going on here that we just cannot get comfortable in this 6-month flex. We have to be actionable every month until then. So preparing for the transition now means we have some time to plan. So now that we're not going backwards on April 1st, but now we have to look to October 1st. We have a link here, and this link here helps your states. It helps you with your state's telehealth resource center. So you can have your clinic leaders or coding and billing team establish relationships with these centers. So when you click on this link, when we send this out, you click on this link and know who the center is for your state. Make those connections. And what else do we need? We need data. Clinical data reports to help evaluate the impact on your patients. We have to identify how many patients are currently receiving telehealth services that are outside of an approved originating site. Determine how many of these patients might face barriers to in-person care if telehealth is no longer an option. What is going to be their capability to get to you if they can't, if telemedicine goes away from that perspective, from their home? Determine how many of these patients are dual eligible for both Medicare and Medicaid, because that's the population that's going to be hit first. And then we have to assess how many patients would be able or willing to go into self-pay payment for telehealth services. And we also have to evaluate our financial risk. And it's a reminder that pre-pandemic CMS telehealth list was about 100 services. But since the pandemic, that has more than doubled, and we'll talk about that later, in telehealth services, which could literally change overnight on October 1st or September 30th. So we also have to consider and assume that after September 30th, Medicare will no longer reimburse these telehealth services, and practices in these hospital health systems, but practices, we have to make some decisions. Do we continue offering telehealth to patients without reimbursement? Probably not. Do we allow all existing telehealth appointments to proceed, but stop scheduling new ones? Got to look at the time frame. Allow existing telehealth appointments to proceed up to a certain date and then allow for the transmission of communication and sending cancellation notices? Or do you send immediate cancellations? Now, this will all be getting closer to the date, like not now. But I mean, I just can't believe that we have to have this discussion. We just have to assume that on October 1st, we are going back to the basics. Assuming is the best position that we can be in right now. We have 6 months to prepare for this. And then you also have to assume that even if it is reinstated after they see that it's not working to remove these telehealth flexibilities, that we can't retroactively bill these government programs. Now, communication preparedness. We have to prepare patients, but we also have to prepare our providers. We have to prepare our staff. We have to prepare our clinical teams. So we have another link here for you. This is a link where you can type in a site's address, your site, and just as you begin to build this up for your patients, and this will let you know right away if this is a Medicare originating site. So this can all be a part of that communication with your patients, as well as and understand and building partnerships. But we will need to draft clear and proactive patient notices explaining these upcoming changes. So we got to post them in your waiting rooms. We want to give these patients these links and these phone numbers. Patients can put out these distress calls as well to help support providers in making this known that we do not want these flexibilities to go away. We don't even need to call them flexibilities anymore. Let's just institute this just as a commonplace thing that needs to happen. You also have to begin to think about your advanced beneficiary notices, your ABNs, and having that communication. For one, these will still be Medicare covered services. So you can only administer an ABN when the service is a covered Medicare service. If it is a non-Medicare covered service in the first place, you cannot administer an ABN. So what's happening, or to clarify, that means these services, there's all these services, over 200 services listed on the CMS telehealth services list. So that means these services are covered telemedicine services. But what happens in any Medicare covered service, there might be criteria that you do not meet, which means that that's the indication that you need to issue an ABN. So you have to know, first of all, that this is, first of all, a Medicare covered service, but based on the patient's location or geography, we know that Medicare is not going to cover it because it's not an originating site, but this is a covered Medicare service. So you have to have those ABNs in place. The reason why, you have to know the exact reason why is based on the patient's location or the geography, and then exactly how much that cost will be. So we know that given those administering those ABNs, and you can't administer the ABNs as a routine, that has to stop. We can never do that. When the patient walks in the door, they just fill out an ABN. ABNs have to be exact. And so this is just being fully transparent with your patients, and your patients have these options. They can say, well, I want you to bill Medicare first to see if Medicare pays. If they don't, I'll take the responsibility. Or B, they can say, well, I don't want you to bill Medicare at all. I will go ahead and set up this payment plan with you, or I don't want the service at all. So just a reminder of what those ABNs are all about. We also have to ensure that providers and schedulers understand these new requirements, plans for your multiple distribution channels and mediums, which could be email, the patient portals, your office signage, even your website updates. It's going to be that serious as we get closer. The greatest thing here, as far as wrapping your arms around your patients, is identifying those alternative care options. So these are for patients that are unable to come in person. And so do they have any sites accessible to them that they can get to, because they can't get all the way to you, that would be considered an originating site? So again, these links that we have for you, you can also look and identify in your patient's geographical areas if there are some sites that they can actually get to continue to receive the services from you. And you can also explore those partnerships with those facilities. Just these two links, this link here to know your telehealth resource centers for your states, and then the analyzer to see if yours or any other originating sites are on that list for Medicare. So that kind of wraps it up with some of the contingency plan, and we'll talk about how we're going to be engaged in this more. This is just the beginning. This is not the end. We have to continue the conversation, and we have to keep up the struggle or fight together. We just have to keep the repetition going. And so now that we've gotten that into perspective, we can do just a really nice update or refresher on some of these telemedicine updates for 2025 overall. So here we have now just the CMS telehealth list alone, 282 services are listed on the CMS telehealth services list for 2025, 282, which could change as of September 30th, 200, almost 300 services. How many are we utilizing though? It's really time to go in and start getting familiar with these services, because there are a lot of services out there that are probably so underutilized that they can and will go away if we're not utilizing them. So this is a part of the grand care model that I continue to talk about. You have to make them grander no matter what your specialty is. So we have 115 of these telemedicine services on the CMS list that's considered permanent. And this is like our office visits, 99202 through 99215, psychotherapy, end-stage renal disease management, and on. But we have 167, so more than half that are on the list as provisional. That will be our initial observation and inpatient admission, also like physical occupational therapy. They are on there as provisional. But you can see here for 2025 that Medicare has approved 13 new telemedicine services. And these services are centered around Medicare beneficiaries receiving care at home, outside of the office, where they don't have to leave home. So it seems like such a conflict to have to take it away potentially for the patients to still have to leave home to go to an originating site if that's going to be the case. But there has just been such a big push for caregiver training and for safety planning for our folks that's mental health. The safety planning for mental health is to that's probably going to really stay in place. As you can see here, it is permanent, but that safety planning for folks that have really severe mental health issues, maybe suicidal, homicidal, and it helps you to work with the patient and the patient's families and caregivers and friends and their social environments to help them cope if their patient goes into one of those episodes, and helps the patient with ways to cope with where they are and their social surroundings. So the safety planning intervention is extremely important. And then there's a really big push on caregiver training. So this caregiver training, it's not limited to techniques to prevent decubitus ulcer formation, wound care, infection control, but also caregiver behavior management and modification, because we want to think about sometimes our caregivers also need some care because they are either working with family members or folks that are in very vulnerable situations, and that can weigh in on our caregivers. And these are services that we can provide from the clinic to caregivers and to patients. So just something to really think about here as you expand on your care models in the clinic. We also know that as of January 1st, these 3 telehealth audio only services have gone away. They should no longer be selections in your EHR. They should be deleted. They should not be selected anymore. And if they are and you bill for them, they will be denied because they are no longer in service. And we have replaced live video and audio only with 16 new service codes. but we're going to dive into that a little bit more. Here, as a part of the Grand Care Model, and Welter's always promoting these care model efforts, it's imperative that practice managers and providers are aware of all of these non-physician services that's pertinent to the practice. And as you can see up here in the descriptor, that these are professional services using standardized curriculums, which we like to call protocols as well. Again, many practices have MAs and RNs and technicians and other qualified healthcare providers that can document and provide these services. They may still have to be reviewed and signed by the physician or the advanced practitioner, but let's just think about it doesn't hurt to explore it more. There's no harm in exploring it. Over 282 services as well on the telehealth list. But these are all opportunities, or what we like to call revenue streams in a practice. But the reason why I don't like to refer to them as revenue streams, but it's true, because so many of these services are being performed on a daily basis, and basically even being able to track them is being left on the table. And being able to account for your clinical care teams, your non-billable quote unquote teams time, and you know, the budgets that you have for them, how do you even account for that? So these are some of the ways that you can really be able to track how much we need them in our practices every day. So here are all 16 of the new live video and audio only services. They're both for new and established patients. These are in our new CPT coding book. However, Medicare does not recognize any of these 16 codes. Their reasoning is that they have no programmatic reason to consider these services. And so you say, well, why? Well, again, those 282 services that are on the CMS telehealth list for 2025 does have 99202 through 99215 on there. So as you can see, if you look at new, straightforward, established, straightforward, low, moderate, and high, the descriptors are the exact same, and the times are the exact same to 99202 through 99215. So Medicare says we're not going to take the office visits off, and we have no reason to convolute our list with these 16 new codes when we have the set of codes that represents this, which is 99202 through 99215. And the RVUs are quite comparable. There are some slight differences in the descriptor for audio only, which we will touch on. But other than that very slight difference, the descriptors are the exact same. So here we have a really transparent crosswalk. What CMS says, you know, the crosswalks are just about the same. Everything, the descriptors, the crosswalk, everything is just about the same. So we don't need to adopt these codes into our list, nor do we need to acknowledge them to reimburse them. And so you can see RVU for RVU up until we get to 99215, we see a 0.20% decrease in the RVU. And this is for live video, both new and established patients. And then we have the audio only for new and established. And as I said, we're going to dig a little deeper into that additional requirement in there. But you can also see this RVU crosswalk. And you can see somewhere around the moderate new patient, you can begin to see the difference. There are decreases in the work RVUs for the audio only. And the reasoning behind that is, which is the committee that creates these RVUs, is the RUC. They're the Relative Unit Committee. And so what they did was they determined that it's less work when a provider is just doing audio only, as opposed to an in-person or live video visit, that it's more provider work. So that's why we begin to see such a decrease, and that is their reasoning behind lowering the RVUs for audio only for these codes. And so here we go again, audio only for new and established. So as you can see, evaluation and management, which requires medically appropriate history and exam, and we have, straightforward, low to high, moderate, but that it does require more than 10 minutes of medical discussion. So that means no matter what the time, if you decide to code and bill based on time for your service, there has to be more than 10 minutes in that discussion, those medical discussion. And if you decide to bill based on MDM, there still has to be more than 10 minutes in medical discussion. Again, this is audio only. So they're saying if you're spending about 5 or 6 or 7 minutes talking to a patient, then don't bill it. That's basically what they're saying for these services for audio only. So if it's less than 10 minutes, it's a non-billable service for these codes, whether it's MDM or time. So here we have, we want to start looking at our audio only time statements. So be sure to account for that more than 10 minutes in your discussion. Trust me, CMS and other players, they will be looking for this in medical records, especially if you are billing for these services. If you are coding and billing the office or other outpatient visits, that's a different story we'll talk about in a second. But this really does specifically have to do with this code because this is what is built into these services. This need for more than 10 minutes is not built into 99202 through 99215. And then I wanted to rip it apart a little bit more to say, well, what does medical discussion mean? So I went and I looked and I ripped apart all of our authoritative sources, and it does not specifically state that that medical discussion is only with the patient. It does not, it looks like it might be obvious, but it does not say that, and it says more than 10 minutes in medical discussion. Does not say with the patient. When I reviewed the clinical responsibility, it does not say that it has to be with the patient. So remember, our time is that 24-hour calendar day, starts at midnight, ends at 11:59. And so, when we rip apart what are some examples of time and task, we're talking about preparing for the patient visit, reviewing tests or records, ordering tests, directing the clinical staff, performing your evaluation, and overall documenting in the encounter. But here are some key terms for time and task when we're talking about time that's spent in medical discussion. That is discussing the history of the presenting problems and concerns, counseling and educating the patient or the caregiver, interpreting and communicating results, discussing the coordination of care and goals, communicating with other healthcare providers and appropriate sources. So when we look at what that list of, there's a very straightforward list that we have of what can be included in time when we're coding and billing based on time for our evaluation and management services. But for these specificities of an audio only and for these specific codes, when we're saying more than 10 minutes are spent in discussion, let's point out in that time what that means. So communicating with other healthcare providers and appropriate sources, we usually look at that as providers from other specialties. They are not within your group because any provider in your group, you are considered one. We're counting that as time. And then the appropriate sources are going to be like the licensed clinical social workers, a school teacher, EMS, a police officer, some licensed professional who is considered an appropriate source. So again, that is all of the fixation that is in these services when you code or bill for them. Now, we do also want to start considering our telemedicine statements overall, because it's a reminder that CMS says providers must be capable of live video visits at all times, interactive two-way communication, but the provider must always be able to provide a video visit. So it's either the patient is not capable or the patient says, I don't want to. Those are the things that we would be looking at. And these are just some of those statements that you want to just make sure you're always making it known that you would be capable of providing that video visit. And then just continue to be used to putting where your patient's location is, because that can change. Just getting prepared for that. So this I removed from our 2025 coding updates. This one is more specialized and personalized. And again, the burning question, how should we bill? What should we be doing now for billing? These are recommendations. We are not telling you that this is what you should do. You should want to listen to whomever your leaders are in billing and coding in your enterprises and follow those guidelines. But again, these are very strong recommendations and they have been working. And just a reminder that when it comes to these 16 new codes and seeing how, we already know CMS is not going to pick them up. So that means that the Medicare Advantage, they're going to follow in line with CMS. But typically commercial payers, especially the large ones, they usually fall in lockstep with Medicare, right? So what we have put in place in policy for our clients is to continue to bill 99202 through 99215, whether it is a live video visit or audio only, because these are the modifiers in the CMS final rule that Medicare actually recognizes, and that they say that they will recognize these on our evaluation and management services. So you have your updated statements. You're going to say, I am capable of providing this live conference. My patient joined via video, or patients experiencing difficulties this converted to audio only, or my patient declines or refuses. Some patients just don't want to be on video. And then you are going to, and we urge that our providers are educated enough to apply this, because this is alerting either to coding, it might go into a work queue, or these are some of those efforts to allow these services to go out the door and not have to go into a bottleneck in the work queue. But the provider is just letting us know right away, and the provider is educated on what the modifiers that they're applying. So you have 95 in GT, this is for a live video visit, and then you have 93 or FQ, and these are synchronous audio only. So if you've spent 15 or 20 minutes and you're billing your E&M based on time, or you're billing your E&M based on medical decision-making, and it's audio only, converted to audio only, make sure you get these modifiers on there. I think a lot of our providers are very familiar with modifier 95, but this is really important to take into consideration. And just an FYI, United Healthcare has already said that they are following Medicare. They will not accept these new service codes. And another good way to follow this and track this is to work closely with your denials team. So if you continue moving forward with your evaluation and management service and the appropriate modifiers, and they go out the door, and there is, let's say, a commercial payer that denies them and says this is an incorrect code, then now you know that this is a payer that accepts these new codes. Now you can make your system better with edits, and you can begin to build a payer matrix. So this is what we have been working on with our clients, and it's really working. So here I will just, we're about to head out on the discussion, but I will leave you with this, that we have to plan. Get to know these original telemedicine rules and laws inside and out. Run reports of your telemedicine visits and the reimbursement to begin to understand what the impact can be. Optimize your services in telemedicine over this next 6 months, building out a grander care model, which we can help you with, because we do need to continue to demonstrate that this care and these outcomes are being provided for these patients in their homes. We just don't want to lose out on this service. It's just been doing too much good. Get to know your patient population, their demographics, and if there are originating sites nearby, considering those sites that are nearby and building relationships with those organizations somewhere around 90 days out. And we just don't want to continue to get these last minute clutches. So I'm really just so happy that we have 6 months to prepare. And it's just these pushbacks, this could potentially be the last one. Do I think so? Yes. Will I be prepared for it? Yes. We at Welter would be remiss to get on here and talk about puppies and sunshine. And that, no, let's just all have faith that this is what's going to happen. No, let's get prepared. Let's see. Yes, and this was just another recent update. So here's another link that we have for you. This is the full year of 2025 and all of these services that are being looked at. So I just wanted to provide this for you. This is a 14-page document, full year continuing appropriations and extensions act. This is section by section. And in this document, it's the appropriations for everything that's on the docket, including extensions for funding, spending adjustments, disaster relief, language and intelligence programs, even like livestock mandatory price reporting. There's so much on here, but you can see here out of those 14 pages, this is what is impacting us most here. So you can see that this is true. It is very true. It has passed into law that we have through September 30th. We want you to stay in the know. We provide you with a very pertinent list of all of these sites. These are what we consider authoritative sources. These are what you want to stay connected to. I know we have like Becker's and we have other kind of national law reviews that try to give the most up-to-date information as they can. But when you stay connected to these sites that are government-based, you really have the ability to stay in the know with what's happening with the law, because that's what's going on right now. These are laws and regulations. You know, even if we get another clutch extension, trust me, it could be the last one 2 years post-pandemic. So that's the most concerning thing here, is where we are and how well everything has been going for telemedicine, and just why it isn't a no-brainer. So let's hope that it becomes a no-brainer by September 30th. So we want you to stay tuned for upcoming contingency planning. This will be phase 2 webinars in May. These will be more interactive. We're going to have more real-world updates and data as far as the preparation. We'll always keep up with legislation if there are any changes with legislation, and being a part of the conversation. And you can also email our coding group. We do want to join up and create a really strong work group. So we urge that you reach out to us, send us an email, be a part of the work group, be a part of the conversation, because the American Health Association is saying, let's push together. So if we are able to come together as a group to continue to push for all of this goodness that's coming out of telehealth, we can do that together. But again, we will have some more workshops coming up somewhere around May. So we'll give this a little time, gather some more real world data, and have some actionable items to take away. And so for today's session, here is the CEU. Thank you so much for joining. And we can take some time now. The last QR code that we had for the last visit, someone told me that it went to a dating app, which I'm not sure how that happened, but we've tested this one out multiple times, and it does give you this code directly. And if you do have any issues or concerns with the CEU, you can drop it in right now, or later you can let us know. Here is my direct email. I do love direct communications. I have that open door policy. This is our website, and this is another way to stay in the know with what's going on and when our webinars will be as well.
Thanks, Delana. Did a nice job.
Thank you.
We're going to stay on the phone as long as you guys have questions. We're on here till about 3 East Coast time, 2:47. If you look over on the bottom right-hand corner, there's an icon that looks like a little annotation or a chat box. Click on that. And if you have questions, we have some in there. So, Delana, do you want to take some of these questions that are already coming up?
Yes, I just did see one pop up. Yes, we will be sharing this. This will go out to everyone on our list, everyone that joined. So yes,
we'll be sending out the presentation, and also we recorded this session, this webinar, so that those who have registered and have access to it will be able to get into it and go back and review, because a lot was said today. And a couple other questions coming up.
Yes. So we have Amanda Sanchez. She says, so telehealth can go away completely for Medicare and commercial plans as of October 1st, correct? Yes. That is why this call and our ongoing workshops are so important. So please stay connected. Please continue to stay on these platforms with us so we can keep the conversation going, but also keep that preparedness going. And as I stated, for alternative care options, we have to look at that right away. We have to look at optimizing and utilizing telehealth as much as we can in these next 6 months as well. We're looking at that from a revenue perspective, but we're also looking at some of these sleeping telemedicine services that are on these lists and that are not being utilized. And from what I've been able to see in these audits and education, and when I go on site and I see all the work that's being done by clinical care teams, there is a lot being left on the table. And especially to keep some of that outreach to these patients. And our goals for telemedicine and patients being at home is to keep them out of the urgent care, or to keep them out of the emergency department, to keep them from being hospitalized, and to keep them from being readmitted. So these are some of those really good ways that we can provide the telehealth services, and in utilizing our care teams, our MAs, our RNs, and our technicians as well. There are so many services out here you would not believe that specifically say they are not for physicians and they are not for advanced practitioners. These are for actual technicians and actual clinical care teams. So yes, that we talk about those standardized curriculums and protocols that you put in place for these services, and your care teams can go into the patient's encounters. They can create these notes, and that you have to, and they will know and understand the coding. They can select the coding. They will be in there standing and waiting for a physician or advanced practitioner to look it over. That's what the protocols are for as well. Sign off and get them built. Optimize your care models. And we think about family medicine, internal medicine, pediatrics, and geriatrics, but this goes for all specialties. So yes, we will share the presentation. And I hope that answers your question, Amanda. But yes, it will go away. And the Medicare Advantage commercial policies will follow suit with Medicare, unless they specifically come out with a policy that says we're going to still allow patients to be at home, offering a perk or offering that advantage, but we would have to wait for those reimbursement policies. And as you can see, the major players are already coming in. United Healthcare has already said that they're not even acknowledging those 16 new codes that our coding body just put out. So major payers usually do fall in lockstep with Medicare. So that's why we got to be prepared. And that's through repetition. You spoke about Medicare. Do these changes apply to Medicaid yet? Yes, well, the centers, or when we say that CMS puts these out, CMS is the Centers for Medicare and Medicaid. So I have not seen where they make a stark separation of Medicare and Medicaid, because they say that these are CMS guidelines, but they do talk more in depth about the Medicare patients. So again, this is just a way of having to follow payer behaviors, especially for these new service codes. And let's just, be clear, it is CMS. It is CMS rules. This is our federal government agency who's working with the Congress with these rules. So it could impact Medicaid, absolutely. And as well for billing the evaluation and management services with those modifiers, 9395 or GTFQ. We just recommend doing that across the board and then working with your denials management team to see which payers are requesting those new codes. Could be a Medicaid policy, it could be a smaller commercial policy, but that's really just the only way to keep up with real world data is to kind of monitor payer behaviors. Elaine Ballardes. Oh, thank you so much. This was informative. Thank you so much, Elaine. Miss Trin, Lynn Trin. Oh, okay. So John, we do have someone, Lynn Trin is saying that they did not get the webinar from our last webinar. And then great, so other telephone, what technologies are considered audio only? I am not tech savvy. Sarah, here is my direct email. Can you please send me an email? This is a much deeper discussion and I can help you with that. There are a lot of other audio only services. Let's see. Okay, Ms. Barajas did not get, okay, we sure will. If you did not receive our last webinar slides, or if anything goes wrong with receiving that, please jot down my direct email. You can always send me an email. I usually will get right back to you. Okay, absolutely. Yes, the QR code should take you. So when you pull it up, it's just going to come up. It's just going to look like a text. It's not going to take you like to a website. It may not take you to anywhere like this, but what it's going to do is it's going to bring up this index number. So you can like copy it, you can text it to yourself, or you can write it down. But I have not seen where it like takes me or, takes us directly to the CEU tracker and AAPC or anything like that. Yes. Yes, Ms. Gangles, you will be able to get them both as well. All right. Well, thank you so much. Thanks everyone for joining. It's such a pleasure and a privilege to be here with you, and I hope to see you again on our next webinar.
Thanks, Delaney. Did a great job.
Thank you.
Take care, everyone. Thank you.
Thank you. Thank you, Laurie Swanson and Erica Hetwer, Sarah, Robin Peterson. Thank you. Oh, thank you, Paula.
Love the great feedback, guys. That's wonderful.
Yeah.
Well, you are good, Delaney. We got a good crowd too.
Yeah, that's great. We just have to keep it going.
We will. All right, folks, that'll end this session. Thank you, everyone, for participating. Take care, Delana. Jen, thank you.
All right.
Bye.
Bye.